We are today going to really focus on a couple of different objectives. One is to describe how new and emerging hepatitis B virus therapies fit into our current armamentarium of treatments available, and really also evaluate individual patient case needs to identify which patients need to be referred to specialist care. As part of all of this, we're really going to focus on how to manage your patients once they've been diagnosed with hepatitis B infection. And really, we've laid the groundwork over the last three sessions to really now turn towards management, including when to initiate antiviral therapy and how to monitor patients effectively. All right, so we have our 28-year-old woman who was born in the United States, but her parents, as you will recall from the prior sessions, moved to the United States from Taiwan 2 years before she was born here. This patient was screened for hepatitis B virus. Her hepatitis B surface antigen and core antibody are positive, so we know that she has hepatitis B infection. And this then led us to check some additional serologies. Those additional serologies show that her E antigen is positive, her E antibody is negative, her Hep B DNA viral load is 454,000 IUs per ml, and her ALT is 12. So the question is, now what? So keep this in the back of your mind, and let's try to return to this towards the end of the case for some additional discussion. All right, so it's really good for us to kind of just also start by reminding ourselves that Hep B is preventable through a highly effective vaccine that can be administered in 2 and or 3 doses. The combination hepatitis A and B vaccine is also available in the United States and in many places across the globe. And really, because we have a highly effective vaccine for hepatitis B, and hepatitis B on its own is oncogenic and is a risk factor for developing liver cancer, hepatocellular carcinoma is the first vaccine preventable cancer. And what we mean by that is by preventing hepatitis B virus infection, the vaccine can prevent HCC. There should be an extra C at the end of this here. All right, so the big question that always comes up is when to refer to a specialist. And really part of the goal of this boot camp is to move your confidence needle along a spectrum. And for some of you, even from a primary care standpoint, you might gain enough confidence and comfort through these sessions and other learning and just clinical experience to start managing some of these patients on your own. The thing to be mindful of is that anybody who is surface antigen positive or has infection with hepatitis B needs to be managed for their hepatitis B. And so we need to help come up with a plan. And if it's not going to be through the primary care provider, then referring to a specialist is very important. Infectious disease, gastroenterology, infectious disease, gastroenterology, and hepatology are all common specialties that are pretty well equipped to manage patients with hepatitis B infection. And Hep B treatment should be considered as well in patients who have immune active hepatitis B, who are E antigen negative or E antigen positive. So really independent of that, to decrease the risk of liver related complications. And we're going to talk in detail about the ASLD guidelines for who to initiate antiviral treatment on, and in those who we don't initiate antiviral treatment, how to monitor those patients to see if that changes over time. And then, like I just said, patients who are not on treatment will have recommendations for being monitored regularly, typically every 3 to 6 months, and also to keep in mind the need for liver cancer screening with an ultrasound every 6 months if the criteria are met. And we're going to talk a little bit about that today. So the goals of hepatitis B therapy are really to improve survival and quality of care, prevent disease progression, which we typically mark as fibrosis progression, and also prevent or reduce the risk of liver cancer, prevent mother to child transmission. And in the final session next week, we're going to really spend a good amount of time talking about various populations, including pregnant women, and we'll hone in on this preventing mother-to-child transmission. Preventing Hep B reactivation, which will also be covered in detail in next week's session, in patients who are receiving immunosuppressive or cytotoxic therapies for other conditions. And then also to keep in mind for preventing and treating Hep B associated extrahepatic manifestations. And really the goal of treatment here, the currently available treatments, is long-term suppression of hepatitis B DNA. This is checked by the DNA PCR test to look at the viral load. And what you're really looking for in patients who you are initiating treatment is to have that level undetected or below the lower limit of detection. What you also can look for is the normalization of ALT with initiation of treatment. And again, the real hallmarks of whether or not treatment could be considered to be discontinued with a monitoring plan is induction of e antigen loss, or what we call to a seroconversion, or in the very rare instance, which is typically around 1 to 3%, surface antigen loss, and that's also referred to as seroconversion. All right. So who should be treated? Well, the decisions for treatment are based on hepatitis B DNA, ALT liver disease, the degree of liver disease, and the risk of complications. And family history plays into the risk of complications here. It's important that you think about treating, people who fall into a must-treat category include anybody with cirrhosis or advanced fibrosis and or liver cancer, irrespective of the hepatitis B DNA level and irrespective of what their ALT level is. Other categories to consider in terms of must treat are people who are infected with a Hep B DNA PCR viral load level more than 20,000 IUs, and e antigen positive patients, but we'll talk about how this also depends on the ALT and fibrosis assessment. And then in e antigen negative patients, if your hepatitis B DNA is greater than 2,000 IUs, again, depending on their ALT and fibrosis assessment, which we're going to talk in more detail in the next slide. Other categories of folks to consider treating: those with advanced fibrosis. So you may have 2 or 3 out of the 4 fibrosis scarring if you were to do one of the non-invasive markers or evaluations for fibrosis, or a liver biopsy may show you the degree of fibrosis. And then you also would consider treating anybody with a first-degree family relative with liver cancer if they personally have extrahepatic manifestations of hepatitis B infection. And then generally, patients who are immunotolerant over the age of 30 get a different level of consideration for treatment. All right, so let's take a little bit of a deeper dive into how we put all of this together to figure out who needs to be treated now and who can wait. And in those who wait, how often do we monitor them? So I'll start by saying that the definition of the upper limit of normal for an ALT, irrespective of the different assay you might be using from your local laboratory, for men is 35 and for women is 25. And this is based on studies that have been done looking at healthy adults and then breaking this down by gender. So you see a little asterisk here at the bottom, kind of giving you the ranges for healthy adults with respect to the upper limit of normal for ALT. And so what the ASLD and others have selected is a criteria at that upper limit of that range or just above that, so that we have some standardized criteria when we're talking about that ALT level, because different assays have different reference ranges. All right, so in e antigen positive patients, that's who we're discussing on this slide. If the ALT is less than or equal to the upper limit of normal and your Hep B DNA is greater than 20,000 IUs per liter, these patients fall into a monitoring category with checking ALT and Hep B DNA levels every 3 to 6 months. And you can check the e antigen every 6 to 12 months less frequently to see if they lose e antigen and gain e antibody over time. All right, so the blue box matches to the blue box recommendation below. The next category is somebody who's e antigen positive, who has Hep B infection. but their ALT is above the upper limit of normal. So again, defined as men 35, women 25, but less than 2 times the upper limit of normal. And if your Hep B DNA is greater than 20,000 IUs per liter, the Hep B DNA may represent seroconversion if it's in a range less than this. But if it's greater than 20,000 IUs per liter, it takes us down to the gray box here in terms of the recommendation. So it's really important that we exclude other causes of ALT elevation. So this is where you really want to take a very good history to make sure the patient doesn't have any alcohol history, other liver diseases that may need to be excluded based on the patient's history or risk factors. So making sure that they've been adequately screened for, hepatitis C, since they have shared routes of transmission, as well as HIV and other liver-related issues. And then you also want to, in all of these patients, assess disease severity. And there are a number of ways to do this using non-invasive tests and or a liver biopsy, which we do far less frequently these days, given the amount of non-invasive ways we have to assess liver disease severity. The most common tests you're hearing about these days include FibroSure fiber tests, which are blood tests that can be sent out, transient elastography, which includes things like the FibroScan test that some offices may have available. And if the staging with any of these tests indicates F2, and this is the fibrosis scoring scale, the scale goes from 0 to 4, so F2 or higher. So really you're trying to catch patients who are developing progressive fibrosis over time, or anybody with an A3, which is really a necroinflammatory score. So this is something you're really only going to see on a liver biopsy. These patients, if their Hep B DNA is greater than 20,000 IUs per liter, and their ALTs above the upper limit of normal, but less than 2 times the upper limit of normal, fall into a treat category, okay, with antiviral treatment. And then if other causes of ALT above the upper limit of normal is excluded and the elevation persists for more than one reading, then you want to consider treatment in those patients, particularly in patients who are a little bit older in age, which is defined by the ASLD as greater than 40 years. And then finally, the last category is an e antigen positive patients whose ALT is much higher than the prior 2 categories, so greater than or equal to 2 times the upper limit of normal. If the Hep B DNA is greater than 20,000 IUs per liter, that automatically takes us down to the purple box here, which means that we go ahead and discuss initiation of antiviral treatment. Now, what do you do for folks who have a DNA level that's between 2,000 and 20,000? This may represent seroconversion, so you want to monitor them similar to the category of people here every 1 to 3 months. And if this persists for more than 6 months, they fall into a treat category. All right, so, a lot of times it's hard to memorize all of the things that are on this algorithm. So this is a nice handy algorithm that you can refer back to either in the slide set. If you go to the ASLD.org website, they have different guidelines. And if you click on the Hep B guidelines, this is where this comes from. All right, so that kind of really went over in detail how we manage patients who are e antigen positive. What do we do for our patients who are e antigen negative? Again, we use the same standard criteria for ALT upper limit of normal. So for men, it's 35. For women, it's 25. So if the ALT is less than or equal to the upper limit of normal and the Hep B DNA is greater than or equal to 2,000, that takes us down to the gray box. So again, the gray here correlates with the recommendations in gray below. And if the ALT is less than or equal to the upper limit of normal, you want to monitor the ALT and the Hep B DNA every 3 months for up to a year. And then this should say every 6 months. There's a 6, I think, missing here now that I'm noticing it. If the ALT is elevated, you want to exclude other causes of ALT elevation and assess disease severity with non-invasive tests and or liver biopsy. If staging indicates, again, the patient has more progressive fibrosis as stage 2 or higher, or if you've done a biopsy and their necroinflammatory score reported by the pathologist is 3 or higher, those patients fall into a treat category. And if the ALT is persistently above the upper limit of normal with the Hep B DNA greater than or equal to 2,000, especially in those who are above the age of 40, you're going to probably you're going to want to think about treating those patients and having that discussion about treatment. And then what do you do for people whose Hep B DNA is less than 2,000? These are patients who clearly fall into a category where it's not recommended to initiate antiviral treatment, but rather to monitor the ALT and Hep B DNA levels every 3 to 6 months. And you can also, because the e antigen is already negative here, you can check the Hep B surface antigen annually to see if they're in a lucky 1 to 3% of people who might spontaneously lose surface antigen and be cured of Hep B. Now, that kind of takes care of patients who have an ALT in a normal range. Well, what if your ALT is above the upper limit of normal, again, using these standardized criteria, but less than 2 times the upper limit of normal? Well, really, irrespective of your Hep B DNA, you come down to this gray box here of monitoring, and based on the monitoring parameters and or fibrosis staging, kind of making your decisions about when to treat. And then in those patients who are e antigen negative, but their ALT is greater than or equal to 2 times the upper limit of normal, the Hep B DNA, if it's greater than 2,000, automatically kind of takes us to the purple box here where you should treat all of those patients. And the Hep B DNA, if it's less than 2,000, again, you fall into this gray box of monitoring and needing a little bit more information to make your decision about whether or not to treat. Okay, this has come up, as a question quite commonly from providers. Why not treat everybody with hepatitis B infection? Well, like I mentioned in the very first, the first session or module of this boot camp, where we talked about epidemiology, right? 200 and close to 260 million people worldwide are infected with hepatitis B. It's not cost effective, particularly because many of these infections, more than 50%, happen from mother to child at birth or in early childhood. And treatments right now that are currently available are long-term treatments. So they're not typically treatments that can be stopped. So we don't commit everybody to starting treatment for lifelong. So again, it's theoretical, but not very practical. And then the other thing to keep in mind is that not everybody will develop progressive fibrosis and develop cirrhosis and or develop liver cancer. So what we're trying to do with our strategies, for which there has been a lot of cost-effective data generated, is really select the patients who we think are at risk for developing more fibrosis and have a higher risk of liver cancer, and initiate therapies on those people. And again, the limitations of current therapies, and we'll talk very briefly at the end about where newer therapies are headed, but they're not available yet. The currently available approved therapies do not eradicate infection. So long-term treatment is needed. So once we start treatment, treatment is lifelong. And then the unfavorable cost to benefit ratio based on the studies I just kind of briefly mentioned, and then implications for drug resistance for long-term treatment. We don't see drug resistance, as I'm going to share with you, with our first-line agents, but with some of the older agents that are still available, we see high rates of drug resistance. All right, so we kind of talked in depth about, when to treat a patient, and if you do treat, how to monitor them. How do we monitor patients not on treatment? Well, if you're e antigen positive and you're of younger age, less than 30, and you don't meet any routine criteria for treatment, you want to follow these patients every 3 to 6 months in your practice. And these are a list of the typical tests and how often to do them as you monitor those patients. So the ALT can be checked periodically along with the Hep B DNA. And then we typically recommend to reassess liver fibrosis non-invasively, not invasively every year. So this can be done through tests like the FibroScan test, if you have that available, or other tests that you can calculate using blood tests and age, such as FIB4, OPRI, FibroTest, and FibroSure. And then in those who are e antigen negative, whose Hep B DNA is less than 2,000, you want to follow these patients every 3 to 6 months. Again, these are for patients who do not meet criteria for treatment. The monitoring test should include an ALT, Hep B DNA, liver fibrosis annually. And then in those who are e antigen negative, but the hep B DNA is greater than or equal to 2,000 IUs, you want to follow these patients a little bit more closely every 3 months for a year to see if there's any changes or persistence that may take you into the treat category. And then you can space out the visits every 6 months if things are pretty stable. And kind of talking about in those patients who do meet indications for treatment, this is a list of the FDA approved medications here in the United States. What I've included here in green are your first line drugs. So this includes entecavir, tenofovir, tenofovir alafenamide, which is a prodrug of tenofovir. This was approved most recently in November of 2017. And then we have an older therapy, pegylated interferon alpha, or Pegasus, which is hardly used in practice these days, but does give some patients, a small percentage of patients, a potential shot at finite therapy. Although most of the studies that have been done in this area with pegylated interferon have over time shown that there's a high risk of relapsing back into being surface antigen positive over time. All right, so, and then what's denoted in orange here are agents that have activity against and are approved for HIV. So it's really important in anybody who's dual infected with HIV and hepatitis B that you're actively managing the HIV with antiviral treatment before you make decisions about which hepatitis B treatment to put them on, so that you don't develop resistance against the HIV by just treating the hepatitis B alone. So this is a nice slide kind of really talking about, again, our first line therapies are selected because of the lowest rates of resistance. Again, the rates of resistance with these therapies are anywhere from 0 to 1.2%. Our second line therapies include adefovir and talbivudine. And then our third line therapies are those with the highest rates of resistance, which include lamivudine, which can be as high as 75% after a few years of being on this antiviral treatment. So we really don't initiate treatment with these second and third line therapies. We really go for first line therapies. Sometimes you'll meet or see a patient who's continued on an old therapy, so it's important to know about some of these older regimens. So some of the pros and cons between oral antiviral therapies, the nucleotides or nucleosides, versus pegylated interferon. Well, the pros, obviously, oral administration is typically preferred to an injection treatment, which is how pegylated interferon is administered. It's very well tolerated and pretty highly effective at our goal of therapy, which is to suppress DNA when you check the blood levels. The cons with some of the older treatments include resistance, but we don't see this as much in the newer treatments. Duration is typically lifelong for the vast majority of patients. We'll talk about some very minor exceptions. And then long-term safety. Well, some of these newer agents have only been around, as I just mentioned. TAF has been approved since 2017, and even tenofovir and entecavir, we don't have decades and decades of data on, unfortunately, at this time. So there's still, a little bit of concern of, what happens when you have patients who are on these therapies for a very long time, but they're considered safe and very effective and still first line. Pegylated interferon does give patients a shot at a finite duration of therapy, which is typically at a minimum of 24 weeks, but upwards of 48 weeks of injection-based treatments weekly. It can, in some patients, lead to an increased chance of surface antigen loss, which I'm going to show you on another slide, and doesn't seem to have any obvious resistance reported over time. It's a much older drug that we use primarily actually for hepatitis C treatment in the old days, which we don't use anymore. The cons are it's an injection. It's a subcutaneous injection, similar to how patients give themselves insulin. It has more side effects, including fevers, chills, and fatigue. Fatigue really being the overwhelming biggest one. And then can't be used in certain populations of patients, including pregnant women, those with cirrhosis, and patients after transplant because of interactions and with immunosuppressive agents. So if you look at how these therapies compare, here on the upper left, you see a slide with pegylated interferon. And what you see here is what happens to hep B DNA and surface antigen over time during treatment. So we know that pegylated interferon is very effective at suppressing DNA and also inducing higher rates of surface antigen loss. And they've also studied pegylated interferon in conjunction with lamivudine. These are based on some older studies, which also led to increased and very potent suppression of Hep B DNA and pretty good results in terms of surface antigen depression on treatment, but this seems to rebound in both these categories for a lot of people after treatment, 6 months and longer. And then finally, what you see here, again, because this is based on older data with your antivirals, when you're giving lamivudine alone as an antiviral, doesn't have much of an effect on surface antigen depression and loss over time, but is pretty effective in terms of suppressing Hep B DNA and comes up when you stop treatment. All right, so this table is somewhat helpful to just kind of put things in perspective. So you have the different types of pegylated interferon, nucleoside analogs, which include lamivudine, talbivudine, and entecavir. Entecavir is one of our first-line agents. And then nucleotide analogs, which include adefovir, which is considered a second-line agent, tenofovir, and then tenofovir alafenamide, the prodrug of tenofovir, which is the newest available antiviral treatment. So of these, tenofovir and TAF and entecavir are the three first-line antiviral oral agents. So you can see the varying doses. And what you can also see here nicely is the chance at having E antigen seroconversion to E antibody. So again, it's highest with the pegylated interferons, and then also very, different rates, anywhere from 16 to 22% at its highest, or 10 to 22 at its highest for E antigen. But all are pretty effective at decreasing your Hep B DNA, but you can see some of these older agents don't have as high once you stop treatment. So this is, results of at 6 months. And you have the highest rates with really the first line therapy, 67%, 76%, and 64%. So they're just really much more potent when you talk about antiviral suppression than new first line agents. ALT normalization is seen in the highest percentage with some of these first-line therapies, so 72% with TAF, 68% with tenofovir, and entecavir with 68%. And then surface antigen loss is highest with the pegylated interferon at 3 and 7%, but it's still pretty low. And with the newer agents, we usually counsel patients that your chance of losing surface antigen on treatment is 1 to 3% on treatment. All right, and then, so that was really for E antigen positive patients. And what about our E antigen negative patients? So we're only looking here at surface antigen loss. It's much higher for those on pegylated interferon. And again, in those who are E antigen negative, we don't expect surface antigen loss in those patients with the oral antiviral treatments. I'll tell you, most people, as attractive as this might sound, 4%, 7% surface antigen loss, it's really hard to convince patients to take a treatment for 1 to 2 years for at least a year at a shot of a 4% chance at surface antigen loss. And they still need to be monitored if that does happen after treatment. So the mainstays of treatment in clinical practice are really the oral antiviral nucleoside or nucleotides that are first line. So how do you select the first line therapies? Well, it's important to know the age of your patient, whether or not they have bone disease, and whether or not they have any kidney disease. So we know that there are higher rates of bone disease and kidney disease in patients long-term who are on tenofovir. So we typically now, as first-line agents, will start with entecavir and TAF, although tenofovir can still be considered in somebody who's not over the age of 60, in which there's higher risk of bone disease and higher risk of kidney disease, even subclinically. Bone disease can be more accelerated in patients who are started on tenofovir versus entecavir and TAF. So important to know about these side effects and how to pick the best therapy for your patients. terms of the first-line agents. Now, when we talk about counseling patients before we start them on therapy, really the goal of treatment is to move in this direction with fibrosis and cirrhosis regression and reducing your risk of liver cancer. And in patients who are treatment naive, there are a number of factors that can accelerate your course of developing advanced fibrosis, cirrhosis, and liver cancer. These factors include metabolic risk factors such as steatosis, obesity, and diabetes, which we know are very rapidly still growing public health epidemics, if you will, in our patient populations. And so really the goal of treatment is to try to select those patients who we think are at highest risk or already developing signs of progressive fibrosis and try to move them in the opposite direction to stabilize and reverse disease. So the monitoring during therapy, it's recommended that we check at least an ALT and a serum Hep B DNA on any patients who are on nucleoside or nucleotide agents, and kidney function monitoring with at least the GFR and the serum phosphate levels are recommended in all patients treated with tenofovir and any patients at least at baseline who is being selected for antivirals. And then long-term recommendations for things we should be keeping in mind for our patients who are on treatment is liver cancer screening. And this is for certain groups of patients who are on long-term therapy. So we'll talk a little bit about who meets what criteria for liver cancer screening. And it's mandatory for anybody who has cirrhosis or a moderate or high liver cancer risk score at the start of nucleoside or tide therapies. And these risk scores can take into account first-degree relative history, personal history, and some additional factors. The question often comes up once you've started therapy, is there anybody you can consider to stop therapy? So the rule of thumb here is generally most will require indefinite lifelong therapy. So that's the thing we should counsel all of our patients on from the start, that as we are having this discussion about starting therapy, it's important to understand, similar to other chronic diseases, you will likely require indefinite lifelong treatment. And so part of the engagement with the patient needs to be a discussion about once we start, it's really important that you don't stop unless it's counseled based on some of these things below that you could stop. So nucleosides or tides should be discontinued after confirming surface antigen loss. And this can be done after what we call a period of consolidation of treatment. And nucleoside analogs may be discontinued in e-antigen positive patients without cirrhosis who achieve stable e-antigen seroconversion. So if you lose your e-antigen, you become e-antibody positive and have an undetectable Hep B DNA for greater than or equal to 12 months. So it's really important you complete 12 months of what we call consolidation therapy. So you need to have, that's when the Hep B DNA is undetectable. And then after you stop the antiviral therapy, it's important that you continue to monitor these people at least every 6 months, but 3 to 6 months to make sure that the e-antigen does not what we call serorevert or come back. And then in selected e-antigen negative patients who don't have cirrhosis, who achieve long-term, which we define as greater than or equal to 3 years of Hep B DNA suppression, you could stop treatment in those patients as long as you can ensure, really the word guaranteed is what is in the guidelines, that this patient will be engaged in follow-up to see if the viral load comes back up off of treatment. So typically every 3 to 6 months, and then that can be spaced out to every 6 months after a year if the treatment looks like it has worked and the DNA level stays suppressed. Another concept to be aware of when we're talking about Hep B management is drug resistance. So this just kind of gives you an idea of why we've selected our first-line agents to be entecavir, tenofovir, and TAF. Well, the resistance levels, the further out you go in treatment, is 0 with TAF and tenofovir. We have less data with TAF. And with entecavir, it's incredibly low, anywhere from 0 to 1.2% over time. And it looks like that risk of resistance between 3 and 5 years doesn't go up. But you see how this is in stark contrast to the older agents including lamivudine, adafovir, and even talbubudine, which with time, we are most certainly going to expect to see high rates of resistance with those agents. If you do see resistance, you can actually send blood tests for resistance testing to look for various mutations. And this is not a table that we often memorize, but rather refer back to, but tells you R for resistance, S for sensitive, to know what your resistance in the virus is and what treatments to optimally select for your patient. Sometimes you might do this on somebody who's been treated with older agents like lamivudine and adafovir at the start of treatment to know what treatments optimally to select. And then if you do develop resistance on treatment where the Hep B DNA level comes up on treatment, the patient says that they're taking it consistently, and you can look for various resistance, and then we have a strategy to switch to various agents or add on depending on whether or not the patient's been on prior therapies, and if so, what therapies they've been on. All right, so I think we now kind of want to move towards the end. We'll start with this case discussion. I still have a few more slides after this where we talk about some of the new therapies. So wanted to pause here and open this case back up to discussion. So we have this 28-year-old woman we've been discussing. She's got chronic Hep B infection. She's E antigen positive. Her DNA is above the upper limit of normal. Her Hep B DNA is greater than 800,000 IUs, and she's E antigen negative. So what do we want to do now? So I think let's open it up, Rachel, here to folks to discuss. So if you're on mute, you can take yourself off mute. Anybody want to chime in? And maybe what I'll do is I'll take us back in time also to our algorithm here. Okay, so this person, okay. So it's hard to toggle back and forth, but does anybody have any thoughts on what we should do next?
Just looking at this patient, she's 28 years old, has a very high viral load.
Yeah.
Also, her ALT is high.
Mm-hmm.
Any imaging in terms of biopsy or fibrosis score that we have?
So that's an excellent question. So you're wondering what additional information can help us make a decision about monitoring, right?
Right.
So let's say this patient, you send her for a FibroScan and she's got stage 2. So this is the E antigen negative algorithm. So somebody who's E antibody, positive. So does that help you make your decision?
Yeah, so she's 28 years old. That's what is the only thing that's holding me. But otherwise, I would treat this patient.
Okay.
And I would choose tenofovir because she is young and can become pregnant in the future.
Okay. Yeah, so we're going to talk in the next module about how TAF, we don't have a lot of data in pregnancy. So women of childbearing age, you typically want to pick tenofovir. And why would you choose tenofovir over entecavir?
Entecavir has, I think the entecavir, there's issues with pregnant women. I don't exactly remember the side effects that can happen. Maybe there is like a very small risk of having congenital malformations, but I'm not 100% sure. I don't know. Yeah,
so the safety with entecavir is actually not as strong. We have more data with tenofovir. TAF, we don't have enough data. And entecavir also has, for women who want to breastfeed, a warning on the package insert as well. So I agree with your choice. Tenofovir is typically what we would select for that patient. Yeah, so it's interesting. You asked for the fibrosis assessment in this patient who's E antigen negative, right? And so what did the fibrosis assessment, if she's got stage 2 disease on the FibroScan, tell you?
To tell me that lot of times you would expect young people could be immune tolerant and have damage. But now she has fibrosis. It's telling me that there's been a lot of inflammation. This has been going on for some time, and this has resulted in some degree of fibrosis.
Right. So she's 28 years of age, so she's very young,
Right.
and she's already developed stage 2 out of 4, right? So
Right.
4 here being cirrhosis. So she's definitely falling into a risk class of patients who seems like they're at higher risk for developing cirrhosis in her lifetime. And so the goal of treatment with you choosing tenofovir would be to try to stabilize disease and decrease the risk of progression of fibrosis and decrease her risk of liver cancer as well, correct? Okay. Any other thoughts about that case?
Just
Okay.
a reminder, if you do want to say something, just to take yourself off mute. Just a reminder.
Excellent. And folks can also feel free to use the chat function if they do think of questions as it pertains to this case.
Yep.
All right, so we can always come back. I have a few more slides, and then I did have wanted to open it up to see if anybody had a specific case they wanted to discuss. So we mentioned a little bit about the importance for keeping in the back of our mind liver cancer surveillance. This is very important. Hep B is oncogenic and is an independent risk factor for liver cancer, independent of degree of fibrosis. And it's likely related to Hep B DNA integrating into the host or person's genome, including insertional immunogenesis of cancer-related genes. The threshold for screening in hepatitis B without cirrhosis for liver cancer is recommended when the annual incidence of the liver cancer or the cancer is greater than or equal to 0.2%. Ultrasound with or without alpha-fetoprotein is what's considered cost-effective, and this is based on life year gains. So the ASLD Guidelines has put forth who we should be screening for liver cancer. So all cirrhotics automatically are recommended for liver cancer screening lifelong unless they receive a liver transplant. In non-cirrhotic patients who are infected with Hep B, it's important to keep in mind these following parameters because these represent higher risk groups with respect to development of liver cancer. So Asian or Black men over the age of 40, Asian women over the age of 50, if you have a first-degree relative with liver cancer, and any carrier over 40 years of age with persistent or intermittent ALT elevation and or a high Hep B DNA level greater than 2,000 IUs per ml. So these put you in a higher risk category for development of liver cancer, HCC long-term, and therefore anybody who falls into this category should be recommended for ultrasound with or without alpha-fetoprotein every 6 months. And then there's a note here that's also included in the ASLD guidelines for people living in areas where ultrasound is not readily available or accessible or just can't be done depending on the setting in which you practice. Screening with alpha-fetoprotein every 6 months should be performed, although this is considered suboptimal to doing ultrasound with or without alpha-fetoprotein every 6 months. But they did include this caveat because of the issues around accessibility of ultrasounds depending on where you may be practicing. And then finally here, what you see are kind of the 2017 guidelines with respect to cirrhosis. So ASLD recommends surveillance of adults with cirrhosis because it improves overall survival. We're talking about surveillance for liver cancer, ultrasound with or without alpha-fetoprotein every 6 months. The only group of patients with cirrhosis who are not recommended for liver cancer screening are those with child class C. This is a child Turcotte-Pugh score that unless they're on the transplant waiting list. So these are patients with very decompensated liver disease. And the reason for this is that this goes hand in hand with a low anticipated survival for patients with this advanced liver disease. And so the benefit of doing liver cancer screening is quite poor. And then finally, the ASLD recommends diagnostic evaluation for liver cancer with either a contrast-enhanced CT or MRI if you do pick up something abnormal on the ultrasound that might be suspicious for liver cancer. And the radiologists use standardized kind of criteria now for describing their findings when it comes to liver and risk of liver cancer. All right, so I'm going to end with just a couple slides on new and emerging therapies. So there are a number of new therapies that are being targeted for various parts of the hepatitis B life cycle. And I'm going to show you this on a subsequent slide. They're kind of really targeting different parts of action in that life cycle, all the way from preventing the virus from entering host cells, preventing covalently closed DNA from integrating into the host DNA, and then using biomarkers to try to figure out how we can develop better treatments. So the future treatment options for Hep B include novel direct-acting antivirals and immunotherapeutic agents, many of which are already in preclinical and early clinical development. So there are actually academic centers and big health centers that are recruiting patients for some of these trials. The endpoint that a lot of these treatments are looking for are looking to achieve a cure with surface antigen loss. And this is being targeted through multiple steps in the Hep B life cycle, which I'll show you on the next slide. And then there may be some future treatment options for those who are what we call dual infected with Delta infection, which we'll talk about in next week's session. There are some clinical trials ongoing for this as well. So this is the life cycle of hepatitis B. It needs to enter the liver cell, the hepatocyte. Once it enters, it then it undergoes a capsid dissociation phase, which then leads to formation of covalently closed DNA, which can then get really integrated into the host genome. And as it gets integrated into the host genome through viral RNA production translation, it then undergoes reverse transcription, envelopment, and then released back into the serum. So really new therapies are targeting different parts of this pathway. And what you see here are, this list is ever changing, but gives you an idea of how many different drugs right now are being evaluated for further development in clinical trials. This is, for example, one such drug that's now in phase 2 studies looking at a core protein inhibitor for hepatitis B, which inhibits hepatitis B life cycle at multiple steps, has additional antiviral activity, and really they're studying functional cure in patients who are being recruited for this trial. And the idea being that if we can get rid of the integration of the Hep B DNA into the host DNA, then we can really lead to a cure over time with some patients. All right, so I'm going to stop here and open it up to questions. And if someone has a case that you'd like to discuss, I'd be happy to talk through that as a group. So folks can take themselves off mute and feel free to either type in a question or ask a question.
How soon after initiating treatment, for how many months or weeks, do you expect the hepatitis viral DNA levels to start coming down? And then when do you expect them to be undetectable?
Yeah, so Hep B viral suppression can take several weeks. So I typically will give it 3 months. My kind of really absolute cutoff is somebody whose viral load has come down, but not all the way to 0 before talking about running resistance testing and or talking about switching. The number one thing to always think about in somebody who's got a viral load that's still detectable at the 3-month mark is making sure that you've discussed whether or not they've been adherent, they've been missing doses. If they have, really counsel that patient to not miss doses to reduce the risk of resistance. But I usually, by the 6-month mark, as long as that viral load is still coming down, I'll still follow them out to 6 months to make sure it's gone to not detected. So I think you'll see different providers have different thresholds for when they'll send resistance testing. but really most people are undetectable by the 3-month mark, but if not by the 6-month mark at the absolute latest.
Okay, thank you.
Yeah. What have you seen similar things in your practice if you're doing treatment for Hep B, or something different?
I see similar things, but I have one patient who took at least more than a year for the virus to be undetectable, and that had been, this was something completely different from my usual observation. I don't know if she was not compliant or what else was happening. Again, alcohol can also cause non-response to treatment, so I don't know if that was the issue.
Mm-hmm.
So there was one case, and I just thought wanted to check with you what your experience was.
So let's talk about this case a little bit more. Did the viral load, has it gone down and up? Has it fluctuated, or has it kind of come down and been at a very low level of still being detected?
So the viral load to start with was about 2 million
Okay.
copies, and then came down to 4,000 at the end of 6 months.
Okay.
And then it remained at that number at the 9-month mark. At that time, I was not sure if I should be doing like any resistance testing, but because the number had significantly reduced from 2 million to 4,000, I didn't make any changes and rechecked once again in 6 months. And there was still some virus. It was not completely undetected, but I still continued the medication.
And what treatment was the
Uh,
patient on?
the patient was on entecavir.
Okay. And the patient was also, the patient had never seen treatment prior to entecavir, is that correct?
That's correct, yeah.
And the patient's actively drinking alcohol, or you suspected
I
alcohol
was
use?
suspecting, even though the patient said was not drinking.
Okay. Yeah, so this kind of case can be a little bit hard to tease out. Again, I always take a step back and think about what's the goal of treatment. And the goal of treatment is to try to suppress that virus. So if you went from 2 million copies down to 4,000, you are suppressing the virus.
Right.
Ideally, we want to see that virus down to undetectable to really kind of really have optimal management and highest chance for somebody who's taking now lifelong treatment to reduce their risk as much as possible for fibrosis progression and liver cancer. I think it would not be unreasonable to do resistance testing at the 9-month mark after you've passed 6 months. It wouldn't necessarily lead me to stop or switch therapy, although unless the resistance testing showed me something that said, you had some resistance to entecavir. Some people who have seen lamivudine or a strain of the virus in which somebody may have been treated before with lamivudine can also have lead to higher, very small rates, but higher rates of resistance with entecavir. Sure. What dose of the entecavir are you using? The 0.5 milligram or the 1 milligram? Yeah. The 1 milligram, yeah. So if you were on 0.5, you would want to make sure that they're on the 1 milligram dose, and that would be what's recommended for somebody who's seen lamivudine anyways. Okay. And so your plan is, it sounds like you have a pretty adherent patient, though, comes in for follow-up regularly.
Very regular, yeah.
Yeah, so I think as long as you keep your eye on the Hep B DNA, you can see kind of what happens over time.
Sure.
Do other folks have any other thoughts about that case? Maybe something you would do differently? A question about that case? Okay. And Rachel, do we have enough time to go over a quick case?
Yeah, I think so, Ponni. If you've got time, we definitely do.
Okay, so for those of you who can still stay with us, I do have a case that we can discuss. And if you have to leave, I want to be mindful of those and respectful of those who have, other obligations. So for those who can stay, please do. Can everybody see my screen now?
Yes.
Okay, so here we have, this is a case of an African born male. So this person was born in Nigeria in 1975. It's a man who has a BMI of 25, who is tested essentially for hepatitis B, and I'm going to show you the test results below here. But the hepatitis B surface antigen test is positive. There's 6 people who live in the household. Household members, some of whom have not been referred for testing and vaccine. As a reminder, we would want to, and anybody who tests surface antigen positive, make sure that household members have also been tested. It looks like 1 here has, and 1 has known infection. A few have been vaccinated. There's a family history. The Hep B just got diagnosed this year. Family history of liver cancer in this patient. And that's the extent of what we know. The patient also has hypertension, is taking amlodipine 10 milligrams, occasionally takes some traditional medications for body aches. That's the best history we have from the patient. And here are the test results. And sorry, they should say 2019, not 2015. So the surface antigen is positive. They're E antigen negative. Their Hep B DNA is, above 900,000 IUs. Their core antibody is positive. And as I mentioned, the E antigen is negative and the E antibody is positive. You've also screened them for hepatitis C, which is negative with their antibody test. And these are your basic blood work results that you check. In July of this year, the white cell count is 5, the hemoglobin looks normal, platelets are 289, the creatinine is 1.2, the ALT here is 96, the AST is 84, and the total bili is 2, the INR is 1.4. Alpha fetoprotein's also checked and comes back at 15. The upper limit of normal is 9 on most assays. So let's stop here for a second. What would you want to do if you're first seeing this patient who's surface antigen positive? So you know they have Hep B infection, they're E antibody positive, their viral load is 800,000 IU, 900,000 IUs, and they have an ALT that's elevated. Do we have any folks who want to chime in?
No, I would do elastography and do an ultrasound scan before I see the patient.
Okay, so great baseline tests. All right, and I want to open this up for everybody to kind of chime in. So now you send them for an ultrasound and it shows echogenic liver. And you also do a FibroScan because you have that available and it comes back at 8.6 kilopascals. So I'm going to include the interpretation for FibroScan here, and it depends on different liver etiologies. Let's see, I want somebody to help practice reading the chart. So we know that the transient elastography score is 8.6. Natalie, Rita, Chienchi, Philippe, anybody want to chime in on what that translates to? If you look at this graph.
This is the first time I've ever seen one of these, so I'm out.
Okay, so what I'm going to show you is at the bottom is the liver stiffness score in kilopascal. And I want you to focus on hepatitis B up here. And what you have here is the fibrosis level on a score of 0 to 4. So if this person's stiffness is 8.6, that would put us right here. If you follow this up to hepatitis B, that'd put us in the orange category of F2 to F3. So that's how you put together the score in looking with this graph and with the various liver etiologies. So this patient has F2 to F3 fibrosis. Your ultrasound's pretty non-specific, doesn't show anything concerning for cancer.
So I would move ahead and treat this patient.
Okay, and can you explain a little bit why you make that decision?
He's a male who is 40 years old, has high ALT, that is more than 2 times normal. He also has F2 fibrosis, and then he's got a very high viral load that is more than 20,000. He is hepatitis E antigen negative, so that would have meant that the viral load, even if it's more than 2,000, and his ALT and AST is 2 times more than normal, then he would have been a candidate for treatment. So he falls in that category for treatment.
Yeah, so independent of having all of these test results, you know that based on the ALT level, right, and the Hep B DNA level and an E antibody or E antigen negative patient, this patient's already kind of moving in that category of treatment. Now, you also have some additional information that I gave you, including more advanced fibrosis. And then the other thing I mentioned was that there was a family member who has a history of liver cancer. So it's good that you sent this patient for an ultrasound, just to know at baseline what their liver looks like. And then would you continue liver cancer screening in this patient?
Yes, he's from Nigeria. And so for people who are born in Africa, according to the guidelines, as far as I remember, it was if somebody is aged more than 20 years old and they have hepatitis B infection, they need screening. So he's definitely older. So he falls in that category, so he needs screening.
Yeah, so he's above the age of 40. So, you know, the ASLD guidelines actually got updated this 2 years ago, in last year in 2018. So the older guidelines say exactly, Sadesh, what you mentioned, that it used to be African men above the age of 20 were recommended for screening. Right. They've actually revised it now to say above the age of 40. The folks, including Nora Terrell, who headed the guideline development for Hep B that got re-released last year, really has mentioned that we don't have enough data in African-born persons living here in the United States to understand what the threshold for treatment and liver cancer, if it should be the same. So based on the data that's available, they've now changed it to be 40 instead of 20. But those patients might be in a higher risk category based on the guidelines. Definitely if you're above the age of 40, you should be put in the category of, and you're a male, for cancer screening. Okay. Any questions or comments or questions about this case? Any questions or comments about treatment, how to manage patients who are infected with Hep B?
This is Natalie. Why was one of the categories Black men in general over 40 and not Black men, Black immigrants?
Yeah, so they don't have enough. Yeah, it's a really good question, and it's a question I have actually directly asked Nora, who headed the guidelines committee. They don't have enough data. So African American men seem to be at higher risk who have Hep B for liver cancer as well. I think we all believe there to be even a higher risk in African-born men. So treating them all kind of like the same probably isn't the right strategy. But unfortunately, we have not had enough large-scale studies done on just African-born persons to inform our guidelines to be different. So up until the most recent guidelines, the liver cancer HCC guidelines included, you know, in African-born men above the age of 20, so that's, as you mentioned, were recommended for screening. That's kind of now been trumped with these revised guidelines to now just include Black men over the age of 40. So it doesn't distinguish between African-born and African-American. And I think it really speaks to us needing more data in this area to help clarify the issue, because I believe, because of a lot of the work that we've been doing in African-born communities in New York and other places, that the risk may be different. And we need to tease out what those differences are with better data, but we just don't have it to inform the guidelines at the moment. Great question.
I have one other question. One thing I found confusing between last week's presentation and this week's presentation was last week you specified the difference in your summary charts between BE antigen positive and BE antibody positive. And today, throughout the conversation, you were just talking about BE antigen negative or BE antigen positive. So I finally, during this case, started wondering, whenever you talked about BE antigen negative, were we supposed to assume that they then were BE antibody positive?
Yes. So, in real life, sometimes you might be in the in-between phase of losing E antigen and waiting for the E antibody to appear. So the guidelines are very specifically written with respect to treatment, with respect to whether or not somebody's E antigen positive or negative. So there are some cases where somebody might be in that in-between phase where their E antigen's negative and the E antibody hasn't become positive. And then we have also, very, very rarely seen exceptional cases where you lose E antigen and don't develop E antibody in somebody who's got chronic hepatitis B. So I think to account for those facts, the guidelines really stick to the E antigen status of the patient. We also know that so I think when you're talking about like last week's talk and the talk before, we showed those phases where you start with E antigen that's detectable and then you develop E antibody. That's still the case, that the vast majority of time when your E antigen's negative, you will have E antibody. But the way the treatment guidelines are written are really with respect to whether or not that E antigen's positive or present because of that window of seroconversion. Does that answer your question, Natalie?
Yeah.
It is a confusing point. We tried to kind of mirror the way the guidelines were stated. So I think adding maybe more description in the earlier sessions that treatment really hinges on the E antigen status might better prepare us for when we present this module.
If we had been able to use some of the information from last week, superimpose that on this week's module, that would have been helpful for me since this information was new for me today.
So kind of recap some of that information, is that what you're saying?
Or use some of the information from last week's slides in presenting this week.
Okay. I think that's helpful feedback for us to take back and discuss how to best incorporate it, I think, going forward. So I appreciate it.
So I have a question with regards to Vimlidi. What's your experience been so far in terms of Vimlidi? I've only used it on 2 patients. So far, everything is working good, but what's your experience been?
Similar to yours. So, on patients who are older, who are at higher risk for developing bone disease or do develop bone disease, it's an automatic switch. Not having much in the way of insurance coverage approvals. So you practice in Canada or you practice in the United States, remind me?
It's practiced in the US.
In the US, okay. So haven't had much in the way of insurance approval issues, which is kind of a practical kind of part of our treatment regimens. We've also now put it on formulary in our health system for patients who are already taking it, so we don't have to talk about switching them if they get admitted for some other medical condition and don't have their medications on them. But I'd say overall very positive. I'm not seeing any blips with like the GFR that we saw with some of the patients with who are on tenofovir therapy. So as much as possible, I think we're moving most patients over, particularly aging populations, to Vemlidy or TAF, for those of you who may not be familiar with the brand name.